Good afternoon, everybody, and welcome to the final of our COVID update webinars. I think it's no coincidence that the week after we announced it was going to be our last one, the Prime Minister ceased his 5 o'clock briefings. He's obviously following our lead. So the last 12 weeks, thank you to everyone that's attended. I've certainly enjoyed it, speaking to people all across the NHS on what COVID's meant for them and the impact it might have going forward. This week, we have a special guest, Stephanie Edusei, who is currently the Chief Executive of St Oswald's Hospice in Newcastle, but has a fantastic career. She's worked across Foundation Trust, CCG, community voluntary sector. I'm probably missing out lots of other things. I think you've worked in the ambulance service as well.
Ambulance, yeah.
Has a fantastic perspective on what's going on in the NHS and what might be happening in each of those different areas. So the theme of our conversation this week, rather than thinking about what has happened, we're going to take a look into the future and try and uncover a bit of what the future needs to look like for the NHS and how we might get there. So Steph, welcome. Thank you for joining us. Before we get stuck into that conversation, obviously you've just started at a very interesting time. Could you just give us a 1 or 2 sentence summary, if you can, in what you've seen from sort of slightly outside the NHS in the sort of the social care aspect, I suppose?
Yeah, so I started this role on the 1st of May, so right in the middle of the pandemic. I think from the perspective of the pandemic, what I've certainly seen has been a lot of cooperative working across the northeast. So Newcastle itself has been very good at working as an integrated system, trying to make sure that our the NHS is covered. For things like PPE, they've been very careful to make sure that we've had the equipment that we've needed. They've even lent us testing kits to get a hold of them. But that's gone out into social care as well. So trying to give equipment to social care providers as well. And really a sharing of when somebody's had too much, making sure that we can shift that around the system. So it's actually really shown how collaboration can work when it's needed to. And some big players who wouldn't normally work together have been very close allies through all of this. So it's been great.
Yeah, fantastic. I won't ask you for any names of who those people might be, but I think that's a common theme that we've heard over the last 12 or 13 weeks is around that collaboration, cooperation, and very much having the patients at the heart of everything. That's one of the changes people are hoping will stick. So your phrase that you've corrected me on that you often talk about is people-driven care. Can you just explain sort of what you see that as meaning and how the role that plays in the future of the NHS?
Yeah, so I don't like this whole concept of putting a patient at the centre of something. It sounds very paternalistic, very protectionist. Actually, you're at the centre of something, you're actually quite often hidden from the outside. And to me, patients should be in charge of their own care. We're in the other part of our lives, but for some reason when you're in the health system, you're not in charge anymore. So the idea is about putting patients in the driving seat, and the health and social care system acts like a sat-nav. So it will advise on the right way to go, but it's the patient's choice whether they do that or not. And the sat-nav can say, well, if you take that turning, it's going to take you 3 years longer to get there. But that's still the patient's choice. The patient might say, I don't want to take the route you're telling me to go to because I have X, Y, Z that I need to do, and that's fine. But it's more of a discussion and a collaboration rather than at the moment the way that a lot of patients and, to be honest, clinicians see it is, I'm the expert, I'm going to tell you what to do, and as the patient sits there and says, well, the doctor's told me, so I have to. And that's not the way forward. And I think COVID has helped that a little bit. It's really helped change the whole dynamic and relationship.
Yeah, fantastic. Thank you very much. That's a really good articulation of that. And do you think that way of thinking has become more prevalent through COVID? We've heard lots about patients, you know, self-isolating, having to do more themselves. Have you seen that?
Yeah, and I think there's been a lot more discussion with patients because things have had to be done a lot online, not by the phone. I mean, I called up my GP this morning about something. They are doing telephone appointments. That's it. It means that there is far more of a discussion, and it actually means that power balance that's always been in the system between the professional and the patient leveled out a little bit. But I do think that patients are now saying, actually, I know what's right for me. And you can see that around a lot of the government recommendations where, you know, the government's saying, oh, it's fine, you can do this now. People are going, yeah, I'm not doing anything yet. I'm gonna stay at home. As far as I'm concerned, I'm still extremely clinically vulnerable, so I'm gonna do what I think is right for me, regardless of what you tell me. And I think it's a really good way forward.
Yeah.
We've got patients taking that responsibility.
Yeah, so that's something we've heard a lot about. So for patients to be able to do that, or people to be able to do that, what are the biggest enablers, do you think, in allowing them to take care of their own conditions?
There's a few things. I think that having the information in a way that actually means something. So the NHS and, well, healthcare in total is really good at confusing people. We use confusing language. We talk about really consequential, confusing outcomes. And actually what people want to know is, what are my options? What are the side effects? As the professional, what do you recommend? And then I can make up my mind. And it just needs to be really simple. So we need really simple, straightforward information. We also need clinicians to get out of people's way. We're really good at putting barriers in place and not allowing people to get on with stuff. I think I get it. It's, you know, nobody really goes into health who doesn't want to help people. But what we've taught over the years is that helping people is actually doing for people. So being able to get out of people's way and letting them make those choices and letting them take care of themselves is actually quite a difficult thing for professionals to do. But it's probably the most important thing, combined with really clear, straightforward information. And then it's the kind of all of the technology and everything that backs it up. So, you know, if I have hypertension, what I want to be able to do is easily check my blood pressure, know what that means, and take the necessary steps. I don't need to go and see my GP. I don't need to go to hospital. There's other ways I can access that information. And I think it's been really great to see how technology is working. I saw a great example in Newcastle the other day, and it was a patient who would normally have to come across country from the West Coast to Newcastle hospitals. They've done it all via webcam. It's a cardiac case, and it saved them probably best part of 3 hours travelling and sitting around in hospital for ages. They had it from the comfort of their own home. Their other half was there because they didn't have to take loads of time off work, and it was just such a better experience for everybody involved, really.
Yeah, fantastic, thank you. So, and I think probably no one would argue with the sort of the need from the patient's perspective to do these more responsive things that you've talked about and giving them more information. From an organisational perspective, obviously there's lots of talk around the integration agenda and you know how a lot of change has accelerated recently. What do you think organisations or systems need in order to be able to give that greater focus to the people it serves?
I hate to say this, but we needed a pandemic. That's what was needed. We didn't know it at the time, but I think people.
So we've had that then. So,
yeah. And I think the trick is now not to go back. And whilst it is terrible, the fact that this is not something that's over in 3 months is actually quite helpful, because certainly the position we're in now is we've done all of the emergency stuff. We've done the staff on furlough, staff out working from home, modifying the services. But now we're in the position where I'm saying to the team that we can't keep saying to people, well, we'll see what it's like next month, we'll see what it's like next month. Based on best information out there, this is going to be the next 12 months. So let's just plan based on the environment we're in now is the environment for 12 months. And moving on that basis. So we're starting to put in place some really robust long-term measures. Now, I think it's highly unlikely that in 12 months' time, we will turn around and say, right, well, that worked really well, but we're going to scrap all of that and go back to the way things were. So I think for the NHS, there's a lot, it's going to have to be a lot of what have we done up until now that's worked really well. And I was really pleased to see that in the North East and North Cumbria and Yorkshire and Humber ICSs, they're joining together to really get that learning and innovation now. What's working really well? How do we embed that? How do we take it forward? What's not working so well? What do we need to tweak so that actually we can continue like this for at least 12 months? And then as things do relax and we can really start to go back to the way things were, we won't, because we don't have to, because we've got a really good system in place. It just means we can shake hands again.
Yeah, thank you. One of the biggest planks, I suppose, of the long-term plan, and a big concern for a lot of our audience, is health inequalities and variations in care. And it's something that is inescapable. There's obviously lots of demographic reasons why health inequalities are there. A lot of them are perpetuated by the systems, and there's lots of work being done to try and address variation within the system, which may or may not correlate to those health inequalities. How do you think the NHS can translate its rhetoric about health inequalities into actually some positive action to correct things?
And I think it's a real challenge for the NHS, if I'm honest, because most of the health inequalities don't originate from health. They are things like education, employment. So in this area, we have some real challenges around that. And whilst the future for healthcare provision looks good, the future for those wider social determinants of health look horrendous, if I'm honest. We're looking at massive recession, and we know that in this area we get particularly badly hit by that. So what we're going to have is the poorest people will get poorer, and we already have a kind of real struggle with educational attainment amongst some groups because there's an element of, well, why bother? And that's going to be even more of a struggle. So what the NHS can do, I don't know, but as part of that wider system, there's probably some stuff that can be done to try and balance out some of what's going on. I was having a conversation earlier with some undergraduates, and they were asking me about what we do to attract graduates into our organisation, and other than clinicians, we don't. But for me, it's an area we really need to start looking at, because we can get some real talent, but also if we can build relationships with undergraduates that are long-term relationships, they're more likely to stay in this area, and more likely to be long-term supporters financially of us. And I think that one of the things that's come out of COVID with this change to home working is that we might actually see a lot more of people not having to travel out of the region to work. So that therefore their economic wealth stays, they're spending money here, even though their main place of employment might be a national company. So there could be some real benefits from that, but actually what can health do? It's minimal, if I'm honest. I know a lot of the conversation locally is about trying to spend more money locally. So instead of buying from big national suppliers, buying locally. And doing things like investing in local education and training.
Yeah. Okay. Yeah. I mean, I think that's the social determinants of health, as you mentioned there, are not going to get any better by all the forecasts that we're hearing. In terms of the tech piece, that's one thing that over the last few weeks has come to the fore, that tech is a huge enabler, and there's been a lot of positives with it at the moment. Do you perceive another health inequality potentially around tech there, that some people just don't have access to smartphones or the right kind of data to be able to use it to consult with people or to learn how to use it?
Potentially, although what I would like to see, and I've always said this around tech, when people said, oh, but old people don't use phones, and old people do use phones, especially now, and the amount of 83-year-olds that can use Zoom, you wouldn't believe. But the whole point is, if we're freeing up capacity by using these methods that do tend to be quicker and more efficient, then the people that can't use that, or the people that do need face-to-face, should actually be able to get more, not less. The important thing will be is that whilst the default might end up being a technological solution, it can't be, if you can't access that, you don't get it. And I think it has to be that parallel stream of we're going to really focus on technology and how that can support us, but we're also going to look at how we can support people who haven't got it at the moment to get it. And then secondly, if they can't use that method, we need to make sure that they've got an equivalent, which will probably be the old style face-to-face care.
Yeah, that's really interesting. And I had a very interesting conversation the other day with someone around sort of looking at hybrid ways of working, which is kind of the new term I think that's emerging for us, working from home and going to offices. I'm just thinking from what you're saying there about will NHS services or healthcare services be able to deliver kind of hybrid models, to your point about some people will need remote support or virtual support, some people will need face-to-face. Do you think the NHS has it within it to be able to do those sorts of things?
It kind of is now. And, you know, I've said for years, I'm a reasonably healthy woman of working age. I don't need to go and see my GP frequently, but what I do need occasionally is a chat and a prescription. But what I do is I take up when I do go, I take up a lot of GP time, because they're treating me in the same way that they would be treating a 75-year-old woman with complex underlying conditions, and it's just not appropriate. I think what they're having to do at the moment is treat the simple stuff by phone or Skype or whatever, and then the more complex stuff, they're still seeing face-to-face. The NHS is still doing that, so they're working in that hybrid model anyway. The trick will be, as I say, to still be doing it in 12 months' time, and not to just say, right, but let's stop all of that advice and let's go back to the old way. I do think that's unlikely, if I'm honest. I know that trying to get outpatient appointments and things for years. So this has been a bit of a godsend from that perspective. So I think it's unlikely they'll go back. But what they need to do is when problems start emerging, and they will, at the minute I think a lot of patients are very tolerant, that'll disappear at some point. So when the problems start emerging, what they can't do is say, oh, well, it doesn't work, so let's rip it up. What they need to do is say, well, what about it's not working, and how do we fix that? Not chuck everything out, because that has been a bit of a tendency in the past.
Yeah, absolutely, yeah. So I'm thinking to your recent experience with HealthWatch in particular, that piece around, the way that we should be delivering care, or the NHS should be delivering care, and the patient need or the patient expectation, and there's a gap there, and historically there's always been a gap, and it may be around waiting times, it may be about quality of outcomes. Where are the biggest perceived gaps between sort of patient need and patient expectation and service capabilities?
I've often found that it's more of a perceived gap from a health perspective than it is from an individual perspective. So I once had a conversation with somebody who said, oh, well, people demand too much. And I turned around and I said, actually, they don't demand enough. People are prepared to put up with an awful lot. There is certainly now going to be an issue around waiting times, and people feeling that they are waiting too long for treatment. But the biggest challenge is around handoffs. So you know, I'll contact my GP, I tell my GP everything, I'm then passed on to somebody else who says, oh, it's not us, and it's bounced back to the GP, it's then referred to somebody else, and I tell them everything, and then they pass me on to someone else, and I tell them it. And it's this constant retelling and constant churn and feeling like you're going back to the beginning each time. The better the NHS can get in smoothing that all out and looking more like one system, the better. Because every time that happens, that referral on, that retelling, it's a waste of time, it's a waste of the individual's time, but also the services time. So that's probably the biggest gap, is that externally, the person on the street doesn't understand why there's such a problem passing their information around the system. Those of us that have worked in understand why. It's because we're all not one system, we're all bits. It'll be interesting to see how things like the Great North Care Record really start to smooth that out. And I haven't noticed how that's moved on during COVID. I don't know whether there's been any great leaps, because it would have been the perfect tool to use. But yeah, I think that's probably one of the key things that they need to address, is this seeing people as a whole person. It's one of the reasons I really enjoy St Oswald's, is we do look at people very holistically. So yes, these people may be terminally ill, but they're still people, and they've got lives to live, and so we don't just treat the pain or the sickness or whatever, we also treat their mind, we take care of the family, and they're seen as an entire person. And I think that's one of the real things that the NHS still has to grapple with, is that a patient isn't a patient, they're a person. And that's why I say people-driven care, not patient-driven care, because they're a person.
Yeah, absolutely. Yeah. So, I mean, that is a very, very profound point, I suppose. And in terms of how to achieve that, do you think integration of care will be better for the people of the systems it serves? Is that the way to achieve this?
Potentially, because actually social care tends to be better at that element. It does tend to look at people more in the whole than health does. So there's real potential there. Learning goes both ways for health to start considering far more about what that person may need. GPs are normally quite good at it, because actually what they get is a whole load of social care issues. And the problem is that they can't then do anything with it. So there's real potential, I think, to do that. I think the other thing that may have helped is that a lot of us have had to be everything at the same time over this period. So, like say, working from home, we've not just been, this is the work me, we've also been the work me, the partner me, and the parent me, all at the same time. So we're starting to really get to grips with wearing every hat and being every part of it. And if we can just recognise that and say, well, that wasn't just me, that was everybody. So this person sitting in front of me isn't just a tumour, they're a whole person. I think that could be a real development.
Sorry, I've just got the machine talking back to me. Thinking about that bit and what the whole person looks like, there's a whole load of non-traditional roles, I suppose, or non-traditional organisations that are becoming part of patient care through integration, and think about social prescribers in primary care, the voluntary sector, and community and voluntary sector. What role do you think all of these new roles, organisations are going to play in the future NHS?
I would hope that we have quite a significant role. So one of the things I've learned since coming to St Oswald's is around bereavement, for example. So I can't remember the exact figure, but a very high proportion of young people in the criminal justice system have had a bereavement at an early age, and it goes back to the adverse childhood experiences. So actually there's something about, if you can partner with an organisation, normally in the voluntary sector, that will deal with bereavement, then we could be avoiding a whole lot of other things. And I dare say, I haven't seen the research, but I dare say what you would find coupled with the criminal justice system is also risky behaviour in terms of health. So there's a whole load of things that just by tackling bereavement, we could be making a massive impact on. Health and the voluntary sector have been working a lot closer together over the last few months, and that may well continue. The big risk that we've got, though, is that large elements of the voluntary sector may not be there. We rely very heavily on fundraising. That's been hit just by all of the measures that had to come into place because of the pandemic. But the longer term impact of recession will have a massive impact on the voluntary sector, and a lot of the smaller charities may not even make it through this year. And that
So
will have...
Just on that point, to give us an idea, in terms of your income as an organisation, what proportion of that is NHS, what proportion is charitable funds that you raise or through various means, and is that typical of the sector?
Ours probably isn't typical because we are that specialist then. So about, I think it's about a third of ours is NHS and local authority income for children, young adults and adults. The rest of it is generated through a number of different means. So we have donations and legacies, we have fundraising events, we have our whole retail business, and other, we have a trading arm that sits alongside that. So a huge amount of our income comes from fundraising, for want of a better term. We have to shut all of our shops. We're just opening some of ours next week, and we don't know what all's going to be like with them. So that could take a fair bit of income out. But the bigger hit is things like the Great North Run. We would normally make about 120,000 from the Great North Run. That's been decimated. We've got another event instead of it that we're hoping is going to bring in, but it won't bring in anywhere near what we would normally get from the Great North Run. So we are having some challenges. The hospice in England have been helped out a little bit by the government. We don't know whether that's going to continue, but a lot of voluntary sector organisations are going to be hit very, very hard because all of the means of raising funds are reduced. And we know that even the grants that people would get, a lot of them come from things like endowments. So if stocks go down, there's no money then to share.
Yeah, okay. Wow. So what would the impact on the NHS be then if, well, you know, don't want to articulate what the situation might be, but obviously if there's a chunk of the charity sector that is not viable beyond the end of this year, what would the impact on the NHS be?
It would be huge. A lot of the work the voluntary sector does is the stuff that's unseen that stops people getting into hospitals. It's the kind of that low-level background supporting people. The biggest impact would be on mental health. But then with poor mental health comes all of the kind of health issues, the physical health issues and abuse that comes with that. So I don't think the NHS could actually cope if a large portion of the voluntary sector was to disappear. Just from loneliness alone. I mean, this is one of the big impacts that we're going to see, is that there's a lot of people who've been supported by small voluntary sector organisations who haven't been able to do that because of the pandemic, who are starting to experience quite significant mental health issues. If those BCS organisations were to disappear completely, those people, there's no safety net for them at all. And then we start looking at some of the bigger charities that are doing mental health counselling. They're doing things like drug and alcohol work. They're doing stuff around cancer awareness and training, early years support, just huge amounts of work. I know that if anything happened to us, and we're not talking about that this year, fortunately, the NHS locally has already said they would be extremely concerned. They thought there was a risk that we would go under. Yeah,
okay, thanks. We're nearly out of time, but from our audience's perspective, so most of them are working companies who are looking to support the NHS to achieve its objectives of, you know, obviously delivering the best outcomes for patients. So in terms of getting the NHS to that future state of being a person-driven organisation that's working in perfect harmony, what do you think are the areas that it most needs external support?
I think there's a lot of work actually that probably a lot of the companies are already doing, because this, you saw so kind of disparate and spread out. A lot of the stuff around working at distance. So it's one thing to give somebody the right equipment. It's a completely different thing to actually have that person working effectively, managing them well, and all that type of thing. So there's some real practical learning there around that. But there's an awful lot of service improvement that is going to have to go on. And I know that within the industry there's a lot of experience on how to do that. Really look at pathways and how to map them out. So, for example, you know, we have a lymphedema service. How could that actually be delivered best so that we're stopping people getting to the point of hospital with acute admissions and things like that? What would be the way to treat people, and preferably get them out the other end, rather than them just constantly having to come back for treatment. So I think there's a lot of work that can be done around that service improvement element, and how the knowledge and products that people have can actually help us get to where we need to be. And I think there's also a little bit of work around working out where we need to be. I know a lot of leaders at the minute are kind of going, right, so what does it look like even? So just time and space to sit and talk to others who see things from a different perspective, I think is really valuable. To be able to challenge our thinking, which will still hark back to the way it was all of 3 months ago. And to really say, but why does it have to be that way? You know, you've had your foundations broken up. Why can't you take another step and go that a little bit further? And I think there's some fantastic skills out there that could do that.
Yeah, wonderful. Thank you very much, Steph. And we are out of time now, unfortunately. I could talk all afternoon if we had the time. So thank you very much for joining us this afternoon. And thank you to everyone at home listening. This is the last in our series of COVID webinars. We are looking at different things that we might do in the future. So keep following us on LinkedIn, and we will be in touch when we have something else to bring you. So thanks very much, and stay safe and see you soon.